Hello, my name is Olurotimi Adejumo and I'm from the Center for Child and Adolescent Mental Health in the University of Ibadan in Nigeria. And over the next few minutes, I will be talking about anxiety disorders and trauma, specifically as they present in children and adolescents. And I'll be using this presentation plan. I'll be giving a brief introduction to anxiety and anxiety disorders, what differentiates the different types of anxiety disorders, what is trauma and what are traumatic stress symptoms, how common are anxiety disorders, how may anxiety disorders be managed, and I'll be ending with a summary and a conclusion. So to start with, anxiety can be a normal reaction to stress. We've all been faced with stressful situations in which we experience some degree of anxiety. Things like preparing for an examination or an interview, or having to perform in some form of competitive role like in athletics or sporting events, or even escaping a dangerous situation. In all of these forms of situation, anxiety can actually help us to escape danger or to perform at our best. However, the situations in which anxiety becomes abnormal, when it's excessive or anxiety exists in response to stressors that ordinarily should not provoke anxiety. So a child might respond to some of these forms of anxiety by avoidance. The child might start to avoid the stressor, or maybe hesitant or uncertain about confronting the stressor, or withdraw altogether. And in such situations, anxiety becomes problematic. Anxiety also becomes a disorder when it starts to interfere with a child's ordinary day-to-day performance or day-to-day functioning. Now, anxiety disorders are the most common conditions affecting children and adolescents. One of the reasons why they're very important to be aware of. And they adversely affect self-esteem, academic performance, and they can affect social relationships, which is very important as a child matures. Research shows that a child who experiences anxiety disorders is at increased risk of anxiety disorders in later life and can actually have more severe mood disorders that could actually end in suicide. Unfortunately, anxiety disorders are often missed. One reason why this is the case is because children experience some forms of anxiety, which is normal for different developmental stages. And in the next few slides, I'm going to be talking briefly about some forms of developmentally appropriate anxiety that could tend to make anxiety disorders missed at different forms of childhood development. So in infancy, from about 7 to 9 months of age, it's not unusual for infants to be wary or anxious around strangers. And so a child might be found to cling preferentially to familiar attachment figures when they see a new person or see someone who's strange or unfamiliar. And that's normal. At about 12 months of age and beyond that, a child is also a bit afraid of unusual situations. So a child that's in a new home or in a shopping area, or they're surrounded with people who are unusual, the child might experience some form of anxiety, and you could find them clinging to parents. This, however, doesn't go on for too long. In preschool children, it's not also unusual to have a child who's afraid of one or two different things. For example, a fear of the dark, fear of loud noises, fear of thunderstorms, a fear of animals, and you might find a child who likes to sleep in the parent's bed, for example, when you have a thunderstorm. That's a lot of the time not unusual. And typically, a child is easily soothed in this kind of situations, and the parents can easily calm the child and reassure the child. However, in school age, we find that a child sometimes grows beyond this fear of the dark or fear of animals and becomes more concerned about things that have to do with day-to-day functioning in school. So a child might be worried about performance in class, about getting injured in sports, or little things that typically don't last for too long, and the child typically is reassured and they stop worrying about it and move on. In adolescence, an adolescent is typically very concerned about the way they look, about how they interact with their peers. Are they competent? Are they able to date someone? Are they pretty enough? Are they handsome enough? Are they muscular enough? Things like that make them very concerned about their looks, about how well they fit in with their peers. And it's normally expected that as an adolescent matures, that some of these concerns fizzle out and they become more mature and are able to confront these anxieties and move on to other things. And so in all of these stages of development, there are forms of anxiety that may not exactly point to a disorder, that are normal and expected for this age. Now, in all the forms of anxiety, one of the things that runs through them is an excessive fear, which is characterized by feelings of worry, of apprehension, and dread. And so sometimes the child experiences this unusual gripping fear that is completely out of keeping with the stressor. And sometimes they're afraid that something bad is going to happen to them, or that they're even going to die. And sometimes they experience physiological symptoms of arousal, things like dry mouth, sweaty palms, trembling, palpitations. The child might say they want to go to to urinate frequently. Those are physical symptoms that tend to be associated with these very dreadful feelings. Now, there are different types of anxiety disorders: separation anxiety disorder, social phobia, generalized anxiety disorder, specific phobias, obsessive compulsive disorder, post-traumatic stress disorder. And basically all of them have these symptoms that we've talked about of very significant fear and physiological symptoms. But what essentially separates them or differentiates them are the things, the kind of stressors that provoke these anxiety symptoms. And so in separation anxiety disorder, for example, you have a child who is very, very afraid of being separated from a familiar attachment figure. And so a child might complain about things that would make them have to stay with their parent or their caregiver. It's not unusual to have a child who comes up with headaches or stomach aches when they're supposed to go to school simply because they want to stay with the caregiver and they can't sleep outside of the home except the caregiver is with them. And this happens in separation anxiety disorder. In social phobia, a child is afraid of being the center of attention, and they might have completely avoid social situations in which they're expected to perform or expected to talk or they're expected to do something where people look on. They're afraid of doing something embarrassing or being humiliated. And so in such situations, they could actually avoid very, very severely social situations like going to school or going to parties or eating in public or things like that. Now, in panic disorder, you have discrete episodes that of recurrent anxiety, which is quite severe, and the child experiences physical symptoms like fast heartbeat and rapid breathing, sweating, trembling, shortness of breath, and this is often associated with feelings of being afraid, being very scared that something very bad is going to happen to them. They might die, or persistent concerns about future attacks, so they might start to avoid places in which these attacks occurred. When these attacks occur one after the other, and several of them occur, we start to think about a panic disorder. Now, in generalized anxiety disorder, we have what we call free-floating anxiety in adults, but in children tend to be worried about a wide range of different things, from day-to-day events like are they performing well in their schoolwork, are their clothes clean, are their clothes tidy. You find a child who almost looks for an excuse to worry about everything. So the child is always worrying about something or the other. And they could also present with a lot of physical symptoms like muscle aches, irritability, problems with their sleep, problems concentrating in school, which of course we know can lead to poor school performance. And it's been found that children who have these forms of generalized anxiety tend to be very self-conscious and actually perfectionistic. Now, in obsessive compulsive disorder, we have a child could have obsessions, which are like intrusive images or thoughts or impulses that come into the child's mind that are very uncomfortable. And sometimes the child actually has to carry out certain physical activities, certain rituals to experience some relief from these obsessions. And those rituals are called compulsions. So sometimes you have a child that needs to count numbers in certain sequences, or the child needs to repeatedly go back to check that they shut the door or that they picked something up, or a child has to repeatedly go and wash their hands simply because of the thoughts and the anxiety that comes with the thoughts, and they have to do these things to experience relief. In specific phobias, you have a child who experiences severe anxiety when they're exposed to a very specific stimulus, and this stimulus could be insects or spiders or a particular animal or a particular situation like in heights or an enclosed environment, or it could be a fear of blood or a fear of injections, or things like that are very specific, and the child tends to experience a lot of anxiety when exposed to this, but not when exposed to other stimuli. Now, in post-traumatic stress disorder, there's significantly a very traumatic, stressful event that the child is exposed to, and then subsequently or sometime afterwards, they develop these anxiety symptoms. So you can see that in all of these situations, the anxiety is almost the same, but situations under which they come up are different, and that's what differentiates the different types of anxiety symptoms. Now, we're going to talk about trauma, and there are different ways that trauma has been described, but I'd like to describe it as if a traumatic event has one event which threatens injury or death or the physical integrity of self or others. And so when a child experiences this, a lot of the time they also experience horror and terror or extreme feelings of helplessness at the same time, and this qualifies as a traumatic event that is possible of triggering anxiety symptoms immediately or subsequently. And this, there could be different kinds of traumatic events, and this range very widely from things that affect the child personally, like physical abuse or sexual abuse, to things that the child observes, like in close family relatives, like domestic abuse, or even more vague experiences. For example, a child is just one of several, or is one of several families or several children who experience the devastating effects of a natural disaster, for example. So the stressor could be very close to the child or could be quite removed from the child, but it constitutes a traumatic event, a significant traumatic event, if it threatens injury or death or the physical integrity of the child or others. So it's estimated that rates of trauma experience vary within communities. It's estimated that 2/3 of children will experience at least one traumatic event in their lifetime, and that's quite significant. However, most children don't go on to develop psychological or social symptoms afterwards, but some may develop traumatic stress symptoms. We know that over 10% of children who experience one or more traumatic events may develop stress symptoms consequently. It's actually a lower percentage that go on to meet the full criteria for post-traumatic stress disorder. So post-traumatic stress disorder affects some children, but many more children experience post-traumatic stress symptoms after being exposed to a stressful event. Now, there are some risk factors that increase the likelihood that a child will experience post-traumatic stress symptoms, and these include some of these, like large-scale natural disasters. It's been found that in places where you have very, very large natural disasters that affect a very large number of people, in the aftermath, you have a lot of children who might have post-traumatic stress symptoms. And then if the stressor affects the child very closely, for example, a child witnesses very stressful events in themselves or in very close quarters, they tend to be at increased risk of post-traumatic symptoms. If a child is exposed to repeated reminders of a trauma, for example, a child is sexually abused and they have to interact with the perpetrator on a regular basis afterwards, this increases the risk of developing post-traumatic stress symptoms. And of course, if there are lingering effects of a very traumatic event, for example, a child is involved in a road traffic accident and they have to have an amputation of a limb or some other serious form of intervention, that could also increase their risk of developing post-traumatic symptoms. And of course, if you have pre-existing trauma or pre-existing anxiety disorders in the child. Now, to identify post-traumatic stress disorder, it's important to establish that there actually was a pre-existing traumatic event. And this could be quite difficult because a child could be avoidant. They might not want to talk about the trauma, or if you wanted to find out from an informant, the informant might not be aware about the trauma, or they might be too embarrassed to talk about it, or they might actually be the perpetrator of the trauma, and sometimes this is difficult. Typically, the child also re-experiences symptoms of trauma in various ways, and a child might experience some form of emotional numbing, kind of like they don't experience the same responses, emotional responses to stimuli in their environment afterwards. And they might start to avoid things that give them reminders, for example, the same physical location or the same kind of situations or the same kind of individual who was the perpetrator of the trauma. They could also experience persistent symptoms of hyperarousal, so they could be easily startled, they might sleep poorly, they might be very irritable. And sometimes in younger children, you could actually have unusual fears. A child might actually have nightmares that might not be related to the form of trauma, but you just find an increase in nightmares after the traumatic event, and it could also display separation anxiety. Now, how common are anxiety disorders? Like I said previously, they're the most common mental disorders among children, and separation anxiety disorder and types of specific phobias have been described in children, young children, typically before the age of 12. Now, social phobia occurs more frequently in late childhood and early adolescence, and then you have panic disorder and generalized anxiety disorder coming up much later in late adolescence. Now, some research estimates that between 2.8% and 8% of children experience separation anxiety disorder, and various forms of specific phobias account for up to 10% of children experience one form of specific phobia or the other. Social phobia up to 7%, panic disorder between 1 and 3%, and generalized anxiety disorder in older children, almost more than 4% of children. In almost all of these forms of anxiety disorder, girls experience them more than boys. Now, how can anxiety disorders be managed? In forms of anxiety disorder that are not very severe, you could actually approach it using low-intensity treatment. For example, a child can be introduced to books or CDs or online therapy or information that could help them to understand why they're experiencing the symptoms they're experiencing, especially when they're older children, and are able to cognitively grasp the concepts of the symptoms they're experiencing. And if these are the symptoms are not very severe, the child can actually respond very well to this. This is first-line treatment. However, these are not recommended if you have serious situations like the child is already starting to avoid school for some reason, for some anxiety they experience in that environment, or the child is already starting to have suicidal ideations. You might not want to use low-intensity treatment. So in other cases where the child refuses low-intensity treatment, for example, you may want to use cognitive behavioral therapy, which should ideally be carried out by a trained therapist, or other forms of skills-based therapy that you have access to. You have trained people who can deliver. Now, if these fail or your child is unwilling to participate in this, you might want to use medication management. And selective serotonin reuptake inhibitors are a form of antidepressants which have been found to be helpful in anxiety disorders. And typically treatment lasts between 10 and 15 weeks. It is very important for children or adolescents who are on SSRIs that they need to be monitored for suicidal symptoms. And sometimes you might want to add CBT to that, or cognitive behavioral therapy to that, if SSRIs alone are not effective. Now, before we end, I want to talk briefly about some transcultural issues that it's important to be aware of if you're practicing in some settings, like in certain parts of sub-Saharan Africa. There's a lot of emphasis placed on physical symptoms. For these reasons, psychological symptoms of fear and apprehension may not be recognized as being indicative of psychological distress. And for this reason, if a child has these symptoms, parents might not recognize them as being due to psychological distress, and they might not come for treatment. Similarly, you tend to find a lot of physical symptoms. So a child might come with a lot of somatic symptoms, pains and headaches and body aches and things like that. And it's very helpful to be able to look beyond this and actually look out for anxiety symptoms, because all these physical presentations could be very common in this kind of settings and could be a pointer to anxiety disorders in the background. Similarly, there's a lot of influence of religious and superstitious belief on culture. And for these reasons, even when these symptoms are noticed and they're obviously impairing a child's functioning on a day-to-day basis, they may be ascribed to spiritual attack, especially if they can be associated with a definite stressor. For example, the child is in a certain environment and they experience anxiety. It's very common for people in such environments to ascribe this to some punishment from the gods or from attack of demons or things like that. And it's very helpful to be aware about this and to note that these beliefs affect people's attitudes towards anxiety and how they seek help. It's important to take note of this if you're practicing in these settings or in settings where such beliefs are held, because it helps to counsel the parents about the likely etiology of the child's problems and disabuse them from some of these beliefs, which might lead them to seek help in areas that are not helpful. So in conclusion, we've talked about anxiety disorders. We've said they're the most common mental health disorders in childhood. They're often responsible for considerable psychological distress, and they lead to disruptions in social, academic, and occupational functioning. The central features that run through almost all these anxiety disorders are fear, apprehension, and avoidance, and they're typically associated with physical symptoms of hyperarousal, which a child experiences. Now, in post-traumatic stress symptoms, you have a pre-existence of a significant traumatic event. But apart from that, all the other forms of anxiety disorders are distinguished based on the stressor and what it is that provokes anxiety in the child. We've also mentioned forms of management, and it's helpful to note that anxiety disorders and post-traumatic stress symptoms respond to forms of psychological therapy as well as medication management. And it's very helpful to provide this for a child as early as possible and as soon as symptoms are identified. This helps to improve the outcome, reduce the period of suffering, and essentially ensure that the child is able to return to normal functioning as early as possible. Thank you very much for listening, and bye-bye.